Thank you. Thank you, David, for inviting me. And I learned so much about lung cancer screening today. And thank you for the audience to stay with us for the last session. And you know, it's my great honor to be here and share with you about nutrition as part of the treatment plan for patients with lung cancer through food is medicine interventions. So the first question we want to ask ourselves is why nutrition for patients with cancer? I'm sure the audience here can help name various reasons, but a primary one, and I think which is often overlooked in the current oncology care model, is that cancer patients have increased nutritional needs due to cancer itself and treatment-related nutrition impact symptoms such as nausea, vomiting, loss in appetite, pain, and fatigue, putting them at high risk of malnutrition. Up to 85% of all cancer patients are malnourished, especially those who are undergoing treatment or diagnosed at a late stage. And malnutrition leads to increased inflammation, weight loss, muscle wasting, weakened immune function, reducing patients' ability to tolerate treatment. So as a consequence, cancer patients who are malnourished are more likely to experience treatment toxicities, have increased hospitalizations, which eventually could lead to impaired quality of life and reduced survival. And the scope of malnutrition has now been expanded to include both under and overnutrition, such as overweight, obesity, and diet-related chronic health conditions. So one of my doctoral students, Zhang Li, has assessed diet quality of 3,800 adult cancer survivors in the US, and she says diet quality using the Healthy Eating Index, HEI, which measures how well a person's diet follows the dietary guidelines for Americans. So the 2020 version of HEI has 13 components, so each participant is scored for each component. So when you add the scores of 13 components together, you get the total score. And the total score ranges from 0 to 100. The higher the score, the better the diet quality. So what was the total score of HEI among adult cancer survivors in the US? It was only 54.2. So if you consider this as a grade, this is a failing grade, right? Our cancer survivors do not consume a healthy diet. So despite cancer patient survivors have increased nutritional needs at high risk of malnutrition, they do not consume a healthy diet. So what was going on? Well, just like this morning had a great session about smoking cessation programs, we realized dietary intake is not just personal choice, and there are system-level barriers for cancer patient survivors to achieve optimal nutrition. So one of the barriers is that cancer patients are not routinely screened for malnutrition at diagnosis and during treatment. Only half of the US cancer centers report routine malnutrition screening, and when screening does occur, it is often delayed until advanced nutrition decline occurs. And there's also limited provision of nutrition services as part of the standard oncology care. There's a national survey that revealed that there's only one dietitian for every 2,300 cancer patients in outpatient cancer clinics across the country, and less than 60% of the malnourished cancer patients receive any type of nutrition intervention. And we also need to remind us cancer is a very expensive condition to treat, and adding large out-of-pocket financial burden to many cancer patients, creating and worsening food insecurity, which now occurs in more than half of the cancer patients with low income. So to address the system-level barriers, we need system-level approaches. One system approach I'm going to talk about today is food is medicine interventions. Those are the food-based interventions integrated within healthcare as part of the treatment plan for patients with diet-sensitive conditions. So these interventions represent a spectrum of programs and services, and the most well-recognized or utilized ones are medically tailored meals, medically tailored groceries, and produce prescriptions. So For the sake of time, I'm only going to talk about the medically tailored meals today. So those are the meals that are fully prepared, nutritional tailored to patients with complex health conditions. And those patients often have limitations daily activities, which makes food shopping and meal preparation difficult. And these meals are designed by dietitians based on patient's medical diagnosis and the nutritional assessment. Some examples of the meals are, for example, diabetic or heart healthy meals with carbohydrate and sodium controlled, or low potassium, low phosphorus, and low sodium diet for meals for patients with chronic kidney disease, and the soft and pureed meals for patients with swallowing difficulties, or the meals that are high protein, high calorie for patients experiencing moderate to severe weight loss. And these meals are designed for disease management and to reduce complications rather than for long-term disease prevention. And there is a growing interest in these programs in this country, as now there are 13 US states, including New York State, have approved Medicaid Section 1115 demonstration waivers, which allow the state to use Medicaid dollars to pay for food and nutrition services for patients with diet-sensitive conditions. And there's a growing body of evidence just over the past decades that show that these programs can effectively reduce food insecurity, improving dietary intake, and support mental health, with emerging data also showing improved health outcomes, primarily reducing body weight, blood pressure, and hemoglobin A1C for patients with cardiometabolic conditions. So in a collaborative initiative that we have with UMass Chan Medical School and 11 accountable care organizations in Mass Health, that we found among medically tailored recipients with cardiometabolic disease enrolled for more than 3 months, the recipient had 31% fewer hospitalizations, 20% fewer emergency department visits, and nearly 3,500 lower total healthcare costs per patient compared to non-recipients. Whether these findings can be extended to patients with cancer has yet to be determined. And recently, we completed a multi-site RCT to evaluate a food as medicine intervention for patients with lung cancer. So the eligibility criteria are patients diagnosed with lung cancer who met one of the vulnerability criteria, such as age 65 years older, racial ethnic minorities, low income or no insurance, and who live in rural areas. And most of patients were actively receiving cancer treatment at the time of enrollment, and the participants were randomized into either the interventional control group, stratified by age and cancer stage. So the participants randomized to the intervention control group receive evidence-based nutrition toolkit for cancer survivors that cover topics such as nutrition recommendations during cancer treatment, strategies to manage nutrition impact symptoms, how to maintain a healthy weight during and after treatment, dietary guidelines for cancer survivors. Those who randomized to the intervention group received medically tailored meals shipped and prepared by MANA, which is a community-based organization in Philadelphia. And they ship all the meals in 1 week of supply in the box, put ice and dry ice in the box to keep the temperature low to ensure food safety. And the meals provided in a step-down fashion, meaning the dose was initially higher and then gradually reduced over the course of 6 months. So on average, patients receive about 10 meals per week. And the meals was provided in combination with nutrition counseling provided by our study dietitians remotely. We enrolled a total of 249 patients with lung cancer. You can see the majority of the patients had non-small cell lung cancer, diagnosed at late stage, age 65 years older, and 66% of the patients were screened positive for malnutrition at the time of enrollment. And we evaluate a variety of outcomes. I'm only going to briefly mention about the primary outcomes that we assessed. So one of the primary outcomes is diet quality. And we found that patients randomized to the intervention group significantly improved diet quality, measured by the Healthy Eating Index at 3 and 6 months. And the patients randomized to the control group also had some increase in diet quality, but the increase was modest and was not statistically significant. And patients on both the intervention and the control group experienced weight reduction, over the course of the study, but patients on the intervention group experienced a smaller percentage of weight loss compared to those on the control group at both 3 and 6 months. We also looked at the percentage of patients who experience treatment delays and dose reduction, and for those who are on the intervention group, had a smaller percentage of patients experience treatment delays, dose reduction, and the relative dose intensity was higher in the intervention group than the control group, suggesting that these interventions can potentially help patients reduce treatment interruptions, but none of these differences reached statistical significance. Okay, so I think these results are encouraging, but overall, that the evidence on the effectiveness of these food-based medicine interventions on improving cancer outcomes is still very limited. And there's lack of real-world evaluation of food-based medicine programs for patients with cancer, such as those on Medicaid 1115 waivers. And the clinical workflows to screening, referral, and enroll patients into these programs are not well defined, and actual uptake of these programs in cancer centers and by cancer patients still poorly understood. So I think for the future direction, we need more research to address these major knowledge gaps in order to integrate food and nutrition into oncology care for improving cancer outcomes. So last, I just want to mention, we had our first symposium in December 2024, Food-based Medicine Oncology Care Symposium, which was well received, and we'll be having the second symposium in March 2026. So I have my email address listed here, and thank you for your attention.